Good to see you, good to hear you, good to kind of know you're there. I'm Sharon Davis Murdoch. I'm the co-president of the Health Association of African Canadians, fondly known as HAWC, not hack, but HAWC. And I am here this evening. Rhonda and I are going to host this call, and we have lots of good things to talk about. But before I go any further, I'm going to ask Rhonda to introduce herself.
Okay, thank you, Sharon. Good evening, everyone. My name is Rhonda Attwell, and I am the African Nova Scotian Service Consultant with Public Health. And so essentially my job is to be the link or the conduit between the community and health services. So thank you.
Right, okay. I do want to again welcome all the people who are on the call. I see it just is growing and growing, which is wonderful. So I think it would be appropriate for us to take a moment of silence or a moment of reflection. I'm wondering if Reverend Phyllis Marsh Jarvis is on anywhere. I don't see her. So probably not yet. But I would very much want to acknowledge that our beautiful province is really in a period of mourning right now. And indeed, I do think that we're going to come out of this okay, but at the moment, our heads are spinning and our hearts are breaking from what's going on. So let's just take a moment, and maybe if you don't mind, David, I'm calling on you. David Hawes, who you are muted, but I'm calling on you. Would you just say a word of reflection and in a spiritual way, just help us to sort of close our eyes and just think of others during this time for Nova Scotia. Would you mind doing that?
Okay. As we bow our hearts, we thank you, God, that we know that you're in the midst of this. Our hearts are so heavy because of what has transpired in our province, and added to the COVID-19 situation around the world, here in North America, here in Canada, here in Nova Scotia. We ask you, God, to be with the families that are grieving for lost ones. We pray, Father, that you wrap your arms of comfort around each and every one of them. We know, Father, that the grief is touching every single person in this province and many around the world and in the rest of the country. We know that RCMP are grieving as well because they have lost one of their own, and it must be difficult for them to understand what has happened and how they who are sworn to protect us were unable to do so. There is evil in the world, and God, we just have to turn to you and just cry out to you. And as we take this moment now to reflect and to think about life and to give thanks for life, we just pray your blessing on not only just this meeting, but the province, our politicians, our first responders, our healthcare providers, oh God, and there's so many others that need to have your blessing tonight. And we come to you in Jesus' name. Amen.
Amen. Amen. Amen. And thank you. I know that there seemed to be a message from Dr. Watson-Creed that she's trying to get the link. I wonder if Carla, if you could send that to her.
I'm here. I have it.
Oh, good. Okay, wonderful.
Thank you.
Okay, excellent. Love to see you, Dr. Watson-Creed. There you are. All right.
Here I am.
Good. Okay. So I wanted to, after taking that moment for reflection, I wanted to inform people on the call about HOC's new role, which has really evolved over the last probably 10 days. And that is a role to work with ABSW, the Association of Black Social Workers, to co-manage the COVID-19 response plan. And it's probably, you know, obvious to a certain extent what kinds of work we'd be involved in, but just in a sentence, the response team's role is to mitigate the risk of COVID-19 spread throughout communities and return the community back to a new normal, maybe never normal as we knew it, but a new normal. And we're doing that through education, through precautions and encouraging precautions, encouraging testing where needed, and providing supports. And ABSW is working with us and has in fact begun this and has led this, and then we've joined with them. And some of the supports that are provided include things like, you know, food or groceries for people who are self-isolating, includes lots of information. The HOC side of the plan has been very busy in helping to get information out to make it culturally specific, culturally relevant, plain languaged, and so on. Lots and lots of busy work like that. But that is what overarching the plan is about. Now, Sister Rhonda, you have been on the ground from day one, from the very beginning of things, before even COVID was talked about, perhaps after our first Zoom call, because our first Zoom call was March the 20th. So we were quite early as an organization out there talking about COVID-19, but then soon after you were on the ground. Can you tell us a little bit about your work as it's evolved?
Okay, so yes, the work has been quite fluid, keeps changing based on the needs of the community. So from day one, I'd say that I was linked in to the community where we still meet quite often, to respond to the needs of the community around testing, making sure that we had adequate testing sites put in place, and ensuring that we support the community through that process. That's also involved making sure that we have the right communication that's going out to community, the right educational materials, making sure that they're culturally competent, making sure that we all have the right information that seems to keep changing. So staying updated, staying connected, and supporting the community as much as possible has been taking place. So, and it continues to take place.
Excellent. Thank you, Rhonda. So as we move forward, you may well have questions, and we will entertain those as we go. But for now, I just want to point out that tonight's call will emphasize 3 themes. We are going to have an update, and Dr. Watson-Creed is going to help us with that, talking about COVID numbers, talking about spread, updated information about the virus, because that does change, seems to change, and the importance of staying safe, to continue to stay safe, testing, and when to call and ask for help. We are going to talk about, or we're going to have a focus after that on mental health, the best tips for keeping mentally healthy, but also knowing when we need help and getting the kind of help we need, which in some cases is emergency help. So we need to know when we need it and how to get it. And also, finally, on the call tonight, we're going to focus on rurality, that is the rural needs of people of African ancestry. What is the impact of people living in rural areas? what resources are needed, what are the difference, and what can we do to help. So in a nutshell, that's kind of where we are. And I'm happy to say we're a bit ahead of schedule. So we have a few extra minutes. Let's hope it stays that way. So now I'm going to ask Dr. Watson-Creed. We call her Dr. Gaynor now because we're just so familiar. So I wonder if Dr. Gaynor would talk to us about all of the things that we need to know about the virus and about our situation in Nova Scotia. If you don't mind, over to you.
Thank you, Ms. Sharon, and good evening, everybody. Nice to see you all, and I'll tell you that it's been such a pleasure to see so many people now, coming into the response. Ms. Rhonda, I know you were there early. We had those early conversations, and David and Sharon have been on the phone with me late at night as I've been wrapping my head around, what do we do next? And so many others on this call, I'm sure, Ami Saray, Veronica, I know that you've been in there with ABSW, and I thank you. So pleased to have that level of support from the community. So I'm going to tell you a little bit about where we've gotten to so far in this outbreak, if I can. And for those of you who don't know me, by the way, let me introduce myself. So I am the Deputy Chief Medical Officer of Health for the province of Nova Scotia, which means that I'm the public health, let's say, second in command, and working behind the scenes to make sure that this thing goes away at some point, whatever that looks like and whenever that looks like. And at this point, I have to say, it's probably not soon. So in the meantime, we have to do what we can to stay safe and keep it together. So where we are right now is that in the province of Nova Scotia, we have somewhere in the order of about 850 cases across the province. The majority of those cases are in the Halifax area, so HRM. And if you look at the rest of the province by comparison, you'll see that for the time being, it's relatively quiet. You've heard us talk about flattening the curve. That curve that we're talking about is actually the epidemic curve of the outbreak. And so it's how we track cases over time to see, are we getting more, are we getting more, are we getting more? And typically in an outbreak, that's what happens. So you start with a few cases, they become a few more, they become a few more. Eventually you get to a point where it levels out, and then you start to see a decline on the other side. We are not yet at the decline on the other side, but we are starting to see a leveling out. And in parts of the province outside of HRM, it's always been fairly level. We think that the reason that that's working and why we're not having a rapid sort of increase in HRM, despite the numbers mostly being here, is because the social distancing that we put in place in particular is working. So what it means is that when somebody is infected, they are not able to infect other people because they're not around other people anymore. And that's the only way that this virus passes from person to person is when people are around each other. So we think those measures that people are taking when they're sick, stay home. And if they've been exposed, to stay home so that if they get sick, they don't accidentally infect somebody else. And then all of the other social distancing around not hosting gatherings, keeping 6 feet apart if you're with people that are outside of your immediate family or immediate household, all of those things seem to be working. The challenge right now in HRM is that although that means that we're getting, to a point where maybe we'll start to see that flattening and leveling off of cases in community, we're starting to see the cases show up in long-term care facilities. And so the next wave of the outbreak is going to be there. It's going to be long-term care facilities, prison facilities, basically anywhere that is a closed environment like that is where we're most likely to see cases going forward. Of course, this has a whole different set of implications. Number one is it's harder in facilities to keep the virus from spreading because people are so close. The second is that for many of us, this has implications for our immediate family, right, who are now at high risk if they're in those facilities. And so the message I would give for all of you is this, that the fight right now basically is on two fronts. One is to keep those cases in community coming down by keeping those social distancing measures in place and all of those other things that we talked about. The second is to do whatever we can to keep this virus from getting into facilities. So where we don't have to visit somebody for an essential reason, that we don't do that until this is over. If we are symptomatic in particular, we make sure that we're not visiting people in long-term care facilities, as an example. You know, if we're a healthcare worker in a long-term care facility, being extra careful about who we have been around, where we may have contracted the virus, and extra careful about not going to work if we're symptomatic. These are going to be critical steps if we're going to keep the virus from spreading in our long-term care facilities. It's this next wave in facilities that has the highest potential to overwhelm healthcare systems. And so that's a real risk then to everybody, because if the healthcare system becomes unstable because it can't cope, then all of those services that we're looking to get from the healthcare system become less available to us at that point. And that's what's happened in other parts of the world, like New York City and Italy. That's what we're trying to avoid. So far, so good, but we're not out of the woods yet. There's a new battle emerging around those facilities. I think I might stop there because I know you had some specific questions you wanted me to answer, Sharon, but by way of overview, does that cover it?
I think so. People are certainly I'm prompting you to ask questions. One of the first questions that I want to ask is if you wouldn't mind really breaking it down for us around what the difference might be between being asymptomatic and actually showing symptoms. What does that mean, and what has changed since our first couple of calls? Or has nothing changed, you know?
Well, yeah, it's a good question. And so, the answer is kind of, sort of, it depends, and I'll tell you why. Okay. Anywhere that we see where we have the virus, and it's a relatively closed community, even if it's not fully closed, we have the opportunity potentially to decrease the virus activity as much as possible by testing as many people as possible. So for the most part, we would say it makes sense to test people primarily if they're symptomatic. But if they're in a relatively close community and we think we've got a good chance of getting everybody, there is no reason why we shouldn't be trying to get everybody. And that's been sort of a general theme throughout the outbreak, although in many parts of Nova Scotia, getting everybody becomes impossible because defining everybody becomes impossible. People are coming and going and leaving, and they live here some weeks and other weeks they live somewhere else, and it becomes challenging. In certain communities, we may have the opportunity to test everybody, and so we're doing that. In long-term care facilities, we definitely have that opportunity, so we're doing that. In homeless communities, we're trying to do that. It may not work, but we're going to give it a try to see if we can capture as many of those folks as we can. The challenge is that what it means is we're going to catch people potentially who might be positive, no symptoms whatsoever, and they wouldn't normally have been caught, but because we've used this additional enhanced testing strategy, we've got them. That's a good news story on the public health front, but it's a little bit unusual in terms of, what does it mean for them going forward if they don't become symptomatic? Generally speaking, what we said is if you're positive, we're going to treat you as positive, regardless of whether or not you have symptoms after that test becomes positive. So there's that. If you're negative and you don't have symptoms, it becomes even trickier because it doesn't mean that you won't get symptoms over time and eventually have a positive test. So often what we're doing with those folks is if they don't have a clear exposure, we'll say to them, okay, carry on about your business, but watch your symptoms closely. If it changes, let us know. If they have had an exposure to a case and we're really worried about them, we might say to those folks, we know that you're negative now, but because you've had an exposure, there's now a high likelihood that you could get symptoms, you could become positive down the road. We need you actually to self-isolate for the 14 days, and we'll keep checking in to see how you're doing. And it's in most cases, what happens in those cases is that they become symptomatic during that 14 days. We retest them, and now they're positive, right? So it's a little bit of a complicated jigsaw, but the bottom line is we're not discouraging people from getting tested in most circumstances. There are some scenarios in some communities where we said, if we can get as many people as possible, let's get them, because we've got the testing capacity in Nova Scotia. We are not in the position that the other provinces have been in around that. We have loads of testing capacity right now. It might not hold, but while we have it, we're going to use it as liberally as we can.
Okay.
Does that answer your question?
Yes, I have some other questions about definitions, but Bernadette had a question. Bernadette, where are you? Don't be shy. How about you ask the question yourself? Unmute yourself, yeah.
Okay, thank you. Thank you, Dr. Gaynor, and everybody that's on board here. It looks like we have 53 participants. Excellent, excellent. So my first question was, yes, should we be everybody should be tested no matter if they're asymptomatic or have symptoms. Are you recommending that everybody go and get tested if we can?
Sorry, say the first part of that question again, Bernadette.
Are you recommending that everybody get tested if they can, whether they show symptoms or not?
Not yet. However,
Okay.
I see your online question, and so are you specifically wondering if you live in North Preston and you are asymptomatic, if you can get tested? Is that a specific question, subset of your question?
So part of it is, yeah, if you live in those communities, you're recommending people to go because, like you said, you want to keep the community thing. But what if I live in Hubli, where I'm at, and I don't propose any symptoms? Are you encouraging me to get tested? Not at this time.
Not at this time. And part of the reason for that is the epidemiology of the disease, Bernadette, and where it's tracking in the city right now. So in areas where it's tracking sort of the most intensely, we might say in those areas, let's see how many people we can get. But if people are doing the social isolation and they're staying home and they're not traveling, you know, in different parts of the province and different parts of the city, then the risk of them having been exposed remains relatively low right now in Nova Scotia. Okay. So the need for those people who are not symptomatic is also lower in those circumstances. Does that make sense?
Second part of that question, yeah, that answers it. Thank you very much. Was that the testing stations that are in the Preston area are meant for only people in the Preston area at this time?
Yes, that is correct.
All right, thank you.
Rhonda, I don't know if you have a different answer for that question. I might be out of the loop, but that's my understanding.
Well, there have been some community members who live in other areas but are from the community who have asked for testing in those sites and have gotten it. From my understanding, the numbers are not high, but there are a few. So on occasion, it does happen.
So I saw that there was a message from Lana, and she's not shy. You want to ask your question, Lana? Unmute.
Thank you. Hi, everyone. Keep safe. So I had two questions. One is I noticed that Ontario is starting to capture race-based data. Has our province given any consideration to ensuring we look at that cluster, our own African Nova Scotian health data? As this might be a pivotal time to give some consideration to that and to advocate more strongly for that. And my secondary question is, I work in healthcare, and what I have seen is a prevalence for not just nursing homes, but people in care facilities that take care of people with intellectual and mental health needs, so group homes. And they are scattered throughout this city and throughout this province. And because they're similar in construct in terms of long-term care facilities, but they do not have the medical staff. So there's been a prevalence over the last 2 weeks in our where I work, which is Dartmouth General, to see an increase of people presenting from those two demographic populations. And what's the plan for those vulnerable people?
Yeah, really good questions, Lana. So first of all, on the race-based data collection, I could go on for days about that. Sharon knows this, so I'm gonna try and keep it tight. We are not collecting that yet. I'm just gonna go. We are not collecting that yet in the province of Nova Scotia. I dream for the day where we start collecting this data because it's long overdue. Having said that, I do have the benefit as a result of the work that I do in public health of sitting at some national tables where this is getting asked as well. What I said at those national tables is if the federal government made it a requirement for COVID, it would happen in the provinces and territories.
Oh.
The federal government has the capacity to do that, and actually, I sit on a committee with CIHI, which is the Canadian Institutes for Health Information, which has done a whole big project that some folks on this call may even have been involved in around looking at how do you collect that race-based data. It's ready to be piloted, and so I have put CIHI now in conversation with Public Health Agency of Canada. I'm crossing my fingers that means that the Public Health Agency will mandate race-based data collection as a part of this, but we're not there yet. So I'm not, my money right now is not on the provincial government making that decision, but if the federal government can make that decision, it would happen in a heartbeat. On your second question around the other vulnerable communities and vulnerable sectors, absolutely right. There are a number of tables that have been set up across government to start to support some of those conversations. I'm not sure where they're all at, so certainly long-term care and other residential care facilities are high on the radar, long-term care being highest in part because of the age of those patients makes them much higher risk than in other group homes, particularly group homes for youth and children. We're actually not seeing a high degree of transmission there anywhere in the country. But in general, group living settings are considered to be a high priority for us, as is the shelter community, as I mentioned, which is another fairly active area of transmission right now. So it is on the list. I don't have all the details of those plans, but the plans that are coming out are not dissimilar to what we've already put in place for long-term care.
So Dr. Gaynor, can I just ask you to give us the definitions and the differences between three concepts that are mind-boggling when it's on the ground, and that is or not concepts, but realities, like what is the difference between quarantining, self-isolation, and social distancing within a home?
Okay, and within a home to boot.
Well,
okay.
or yeah, generally, whatever you think is helpful.
Okay, because it all gets a little hard to do inside the house, and I appreciate that. In general, so self-isolation and quarantine are kind of two sides of the same coin. And early in the outbreak, we were actually using the term self-isolation for both, but now we've started separating them. So in general, self-isolation is what we do for people who are sick. They have symptoms, they may even have a positive test and they're confirmed as COVID. That means that they can't go around other people because they will spread it to other people. And you'll remember from one of our early calls, I think I described how this virus spreads. So this is a virus that is spread by respiratory droplets. They come out of your mouth when you're talking, like I'm doing now. They come out of your nose and your mouth when you're sneezing or coughing. And they will generally go only about 2 meters before they fall to the ground. 2 meters is kind of the outer limit. So that social distancing that we talk about, keeping 2 meters apart, is for that reason. If you're not within that 2 meter zone and somebody has those droplets, they're sick and they have those droplets leave their body, they're not going to land on you. And so that means you're not going to get sick. However, keep in mind that whatever they do land on in that 2 meter zone is now contaminated. And if you touch it, now you've contaminated your hands. If you bring your hands to your face, you now potentially have contaminated your mouth, your nose, your eyes, and now introduce coronavirus into your own body, and now you're going to get sick. So the reason for that 2 meter rule is because that's the zone that we know if somebody is sick, they could spread the virus to in that environment. And that's where the social distancing comes from. So self-isolation is what we do with people who are sick. They are not to be around other people because we don't want other people to get the disease, full stop. And that is isolate as much as you can with respect to coronavirus, because it is so easy to spread and has such potential to be deadly. So and when we talk about self-isolation in those circumstances, we're basically saying to people, please stay in your bedroom for as long as you're sick, which is generally speaking 10 days or longer. That's a long time to be isolated in your bedroom, but it's critical. We additionally say to families, if you've got more than one bathroom, then dedicate one bathroom for the person who's sick with coronavirus so that they can isolate themselves to that bathroom, and another bathroom for the other family. And of course, a lot of families don't have that, right? So then it gets complicated. What do you do with somebody who's sick under those circumstances? Because you don't want them to spread it to other people in the household. And so we've now started standing up housing strategies for coronavirus affected people. So sometimes it means take the person who's sick and actually move them somewhere else, or take the rest of the family, move them out into a hotel until the person who's sick is better, if that's what it takes to manage that social distancing in that house while that person is in self-isolation, okay? So that's those two. Quarantine is what we do with somebody who is not sick, but they've been exposed to the virus. This means they might get sick. They might not, but they might get sick
we don't want to take a chance that that happens in an unprotected way. So we ask them to isolate themselves as well, in the off chance that if they do get sick, they haven't already exposed a bunch of people by being around them when they didn't know that they were sick or getting sick, right? So that's the difference between self-isolation and quarantine. Self-isolation is for the people who are obviously sick. Quarantine is for the people who have been exposed. They might not ever get sick, but we don't want to take a chance. So we put them into a form of isolation as well that is basically the same as the self-isolation we would do for sick people. And we wait the 14 days to see if they're going to become sick during that period. And about 20% of folks we're finding are becoming sick during that period. So not an insignificant number. Does that answer the question, Sharon?
I think so. Are others clear?
So can I, Gaynor, can you just add the travel issue? People who are coming in from out of province or coming in from out of country.
Yeah, so that's a whole other level of quarantine. And the reason we're doing that is, so remember I said quarantine is for people who have been exposed to the virus. And they might not get sick, but we don't know if they're going to get sick, so we're asking them to self-isolate. If people have been in a high-risk area in Canada, and there are now plenty, including Toronto, Montreal, Vancouver, Calgary, if they're basically coming from any other province outside of Nova Scotia, we are saying to them, because there is such high activity in those provinces, you probably were exposed. And so we're not taking any chances around bringing coronavirus into Nova Scotia and you bringing it into your family. You quarantine as well when you get here for 14 days so that we can watch to see whether or not you're going to get sick during that 14-day period. So that's where the travel comes in, is that we're deliberate about not bringing coronavirus. We have enough coronavirus here already. We don't need to bring it in from other provinces. So when folks are coming from those provinces where there's been a lot of activity, we are saying to them, self-quarantine for 14 days so that we can see whether or not you're actually going to be coming.
Okay. Thank you. Veronica, you had a question can you pass that question on for us? Okay. I thought I saw a notice here. Okay. Thank you, Dr. Watson-Creed. I know that Bernadette had another question with respect to collection of data, my favorite subject, which I cannot talk about too much because I'll take up the whole time. But please do ask your question, Bernadette.
And I think as part of DPAD, for those who know, I work for the African Nova Scotian Decade for People of African Descent, and we work closely with HAWK with the Health Strategy Initiative. And I think as African Nova Scotians, we're really concerned about trying to get as much data on our people as we can in all sectors. And health is definitely one of the big ones. So I'm wondering during this time why it's not possible for us as a community to do race-based data with a consent form from the people that are getting tested now, or is that going beyond people's human rights or their privacy rights? And if they are willing to consent, because I mean, we know the Prestons is one of our largest Indigenous Black communities, and just having stats from that community alone can certainly set us up for some programming, some different things that we may be able to access through different levels of government to support our communities going forward. And DPAD has come up with an action plan to work towards after COVID and during COVID that would definitely help support any initiatives that we may want to try to do through our organization.
Dr. Gaynor, you want to have a go with that?
Yeah, sure. You know, Bernadette, it's a good question, and it's not a bad idea. The challenge would be that what we want is this data to be good enough that it can be compared to data for other races or ethnicities so that we can see clearly where Black people stand in the mix. And so if we want to do it well, we need to do it in a way that we can actually compare to other groups, because we want to be able to show the disparities that we know exist in Black communities clearly. And so the challenge is that if we only do it for Black communities, and particularly if we don't do it in a way that captures as many people as we can, and to run out because it's not robust enough, right? So it's, you know, totally appreciate the enthusiasm, and not to say that the data couldn't be collected, but then the usability of that data would be compromised a little bit by not having a more fulsome approach.
Right.
But by all means, I would say keep the questions coming, keep the approach coming. Like at some point, that sort of has to unlock so that we actually get that information.
Yes, I have had 20 years of that data wouldn't work because it's not robust enough, and it's not, you know, it's not appropriate. We have to have the whole picture. So I knew she was going to say that. As disappointing as it is, I know that that's our struggle. But my goodness, don't you think we're going to give up? We will not give up. Okay, so moving on to, thank you so much, Dr. Gaynor, for those answers. I think we should, given the time, I'm going to invite Drs. Hawes, Milne, and Cookie to introduce themselves and their roles and to share how COVID-19 has affected their lives and work. And I know that Dr. Hawes has a new role with the plan. So at some point, I don't mind who goes first, don't be shy, but do share that, Dr. Hawes, when it's your turn.
Okay, well, I'll go first. So, hi, everybody. So basically, I'm a HAWK member, and my role with the COVID-19 response plan is basically a consultant role, where when calls come into the toll-free number with medical or clinical questions, then they're passed on to myself and Donna. You'll hear from Donna later on as well. And so in a nutshell, that's what I do. In addition to that, and Gaynor alluded to that as well, is I do keep in touch with my public health colleagues. Even though I'm retired, they're still colleagues. So it's kind of nice to keep in touch with Gaynor and Dr. Sarbu and the nurses as well. So I do play a role in that as well. Sharon, there are two quick things, if I may.
Of course.
Well, so in terms of this affecting me, so I'm retired, but we do have a community-based project that we're doing around education of the Black community for HIV, Hep C, etc., prevention. And that has affected us big time because we're no longer able to have face-to-face meetings and activities. And as I said to you earlier, Sharon, I'm zoomed out because we're doing a lot of stuff on Zoom as best as we can, but it's just not the same.
Yeah.
But there are two concepts I would just briefly want to touch on. One of them, and Gaynor alluded to that earlier, is the whole issue of infectivity or contagiousness, if you will. And one thing I want to pass on to everyone, which you should be aware of, is we're learning a lot about this virus. It's new. There are lots of stuff that is not known by the scientific community. And there's a lot of misinformation going around as well. So just be aware of that. And when you hear, even though things look like they're scientific study from, wherever they're coming from, just check it out a bit more closely. So one of the things that we need to talk about is when is somebody most infectious. And I think for that, we need to separate somebody who is totally asymptomatic. So this person has the virus and never develops symptoms, and then the virus disappears from their body. So if you test them, they'll be positive, but they never develop symptoms. And they're different from somebody who is asymptomatic on their way to developing symptoms. So the first person who is asymptomatic, nobody really knows when is the peak of their shedding of this virus. And that will become clear, I guess, later on. But from what I read, nobody's really sure right now, but we know they can transmit and have been transmitting this infection. Somebody who's on their way to symptoms, the data seems to show right now, the evidence is that they shed most virus in the initial stages of their infection. So there is a pre-symptomatic phase when they will shed the virus and can be infectious. But they seem to have most shedding of that virus when they just develop symptoms. So that's different from the person who's asymptomatic. Just very quickly, the other thing that came up in one of the conversations is the issue of immunity. And again, we're learning a lot about this virus, but the data is not all there yet. So when somebody becomes infected and they get over that infection, they recover, they likely do develop antibodies. Nobody is sure right now how protective those antibodies are. They have to be a certain type of antibody to be protective, and how long that protection would last. So there may be partial protection, full protection. It may last for a month, 2 months, 3 months, a year. Nobody knows really right now how long it lasts. But the assumption right now is that most people, when they have symptoms and get better, they have some immunity, and it's unlikely that in short term they will go back to being infected again. So again, I just want to put that out there, bearing in mind that, again, we're learning as we go along, but those things have come up, so I thought I would address them. And if any of the other docs on the call want to jump in, GAYNOR, anybody else, please do so. And that's all. Thanks.
Thank you, Dr. David. Dr. Ron, what do you want to tell us today?
Okay, well, I'm the physician for Nova Scotia Brotherhood. First of all, just from a personal point of view, I have a 95-year-old mother who's got some health issues, who's still at home. I'm trying not to infect, so far so good. My daughter is a physician in Michigan, in Wayne State, which is one of the epicenters in the US right now, and she's working in a COVID unit.
Oh my.
My son teaches high school, and one of his colleagues is the husband of the RCMP officer who was killed. So I guess I could say I'm in it. Right now I'm in it. Anyway, Brotherhood, we've been involved right from the get-go. The community reached out to us because of the issue with cases that were going on, and I contacted GAYNOR and Claudia to get them involved and try and get some testing up and running and some education and so forth for people about the disease. So I think that's been a pretty successful exercise all in all. There have been a lot of challenges with it, but the thing that's really gratifying to me is to see how the young people have stepped up in the community and really taken a leadership role and really provided a lot of inspiration and showed a lot of love for their community. And we're really grateful for that, because it couldn't have happened the way it has unfolded without that. So we were involved in that right from the beginning, based on our clinics we have in North and East Preston and the relationships Mario and I and Dwayne have built up over the last 4 years. We also did reach out and got Dr. Strang involved after some ill-advised comments were made by him and the Premier. That didn't go exactly the way we had planned it, but I think it was a start anyway of a dialogue, and I think some positive things have come out of it. So from starting with the testing clinic in North Preston, then we expanded to East and Cherrybrook. A lot of pamphlets and education have been given out. Some public service announcements were made to the community, and I think the next thing is the mobile door-to-door testing that's going to happen. So we're trying to get as many people tested as we can there, and that's just an ongoing work in progress. I think just personally, this is really, it's a very sad, but it's a very unsettling time right now for everybody, because not only worrying about your family, your own health. I mean, I just came from the Veterans Hospital. We haven't had an outbreak there yet, and I hope we don't. They're really, you know, I had to get my temperature checked and answer a bunch of questions and put on gloves and a mask and everything just to get into the hospital today. So, and It's annoying, but I think it's good. We need to do it for sure, because if we get more outbreaks, these are the most vulnerable people imaginable that are going to get this disease, and also, of course, it's going to continue spreading. But I think right now we really need leadership, and I think leadership is just being questioned everywhere. I think, as I said, the Premier and Dr. Strang had a few slip-ups. Our police and RCMP are really being questioned now for their role. And it's unsettling also. I mean, every day we're seeing the most powerful man in the world progressively losing touch with reality. It's very scary. It really is. It's a very serious time right now with what's going on. I feel like in Canada we've done a little better, but the challenges are really still there. So I think those are the main points I wanted to make. I just again want to say the people in Preston, the young people especially, the pastors, the community leaders, everybody has really stepped up. And, we're going to continue to work with the community during the pandemic and beyond. And let's hope and pray that, we all come out of it in a positive way.
Okay, well, thank you, Dr. Ron. I know there are questions. I want to be mindful of that, but I also know that the next section we're going to be talking to Dr. Cookie, and we're also going to be talking about mental health, and Rhonda's going to take that piece. So before we move on to Rhonda and Dr. Cookie, might I ask, there were questions coming up with, I think Sobaz had a question, and Veronica Marsman had a question. Can you two pose your questions, please? Veronica?
Sure. Dr. Gaynor, it appears to be that the youngest person that we've heard that has received the COVID was a 10-year-old. So why is it that children who seem to pick up more colds and flus than anybody else are not getting it as much as the adults? Like, what is in their immune system that seems to be keeping this at bay for them, which is a great thing, but it's just a little bit confusing for me.
My question sort of piggybacks on Veronica's too. It's just a question around youth and the virus early on was considered less susceptible to young people. So I was wondering if that's still the view.
Okay.
Related to Veronica.
Thank you both for the question, and whatever young people have can we replicate it so the pattern continues to repeat itself. So I was just on a call with can you hear me?
Yes, we
Hold
can.
on a sec. Okay. I was just on a national call earlier this week where we actually looked at an evidence review that was produced by the Public Health Agency on this question of children. And for whatever reason, remember that a coronavirus is in many ways similar to the cold viruses that we see every year. Obviously, this one is far more serious than that, but genetically it's related. For whatever reason, this coronavirus is not behaving the way other coronaviruses do with respect to infecting children and youth, and definitely not behaving anything like what flu normally behaves like. So normally what we see with influenza is that children are getting the disease, but they're getting a mild course of the disease, but because they're picking it up, they're also transmitting it to adults. In the case of coronavirus so far, the evidence that's emerged, and it's not high quality evidence, keep that in mind. It's not like somebody has gone out and done a big research study on this yet. It's researchers going out and kind of picking up what's happened in different countries and analyzing it for what it is. But what we're seeing from that analysis is that children aren't getting this coronavirus. Not just that they're getting it and they're asymptomatic or low shedders. They're just actually not getting it and therefore not able to transmit it to others. So there's a number of ways, and we think for whatever reason, children are not a major driver of disease in this event, and we just don't know why.
Okay, I'm going to.
I'm sorry, Gaynor, the question about youth, we need to tag that on, if you don't mind.
Yeah, so the data that I'm referring to looked at children and youth up to age 19, and with a similar trend. So it does increase, the risk of getting the virus increases a little bit over the age of 14. That's how the data is cut, basically, but still not seeing nearly the amount of
to and will continue to impact us greatly in terms of use. Admissions to hospital for people developing all kinds of things like psychosis and a lot of suicidal ideation. Actually, there have been already suicides. So this is something that we take very seriously and we're tracking. And so this is all related to what we call like mental illness or mental disorders. In the short version of what's a disorder, like when is it too much anxiety or when is it too much sadness, or the answer really is if our thoughts, our emotions, or our actions are not allowing us to function or causing us too much distress, that's when it's probably something where you need to reach out to somebody. And that doesn't always mean you have to call a mental health care practitioner. Sometimes it's reaching out to a friend, a family member first, a trusted member of the community, a pastor, an imam, rabbi, and just so that folks know, the mental health system is fully up and running. It's one of the sectors of healthcare that we haven't missed a beat. We've been seeing new patients I've been flat out with mostly telephone, Zoom calls, but essentially we're fully functional.
And so just wondering if anybody has any questions. Thank you, Jacob. Does anybody have any questions for Dr. Cookie pertaining to mental health and wellness and how to take care of ourselves? If you do, please, you can ask them now. No? Okay.
I'll just ask for signs of depression when one is clinically depressed. Can you just give us a sense of maybe a couple of points about that, Dr. Cookie?
Sure. Yeah. So clinical depression, depression is a term that depression's a term we all use all the time. You hear it in the news and media. Everybody uses it, and human beings get sad, and that's appropriate. We should get sad. You lose a loved one, something bad happens to us, we lose a job. This is a natural emotion. There are times, though, when our natural emotions we can get stuck in so long and so severely that we're no longer able to function or bounce back or do what we need to do. It can be so bad that we start thinking things that aren't in line with actual reality, and at the very severe end, that becomes suicide and psychosis. And so clinical depression is when it crosses the line from normal sadness into prolonged abnormal sadness that you can't escape for 2 or 3 or 4 weeks or more. Usually depression, the kind of the cutoff line is that if you've been stuck in that state for a couple of weeks or more, that's a sign you should really seek help.
Okay. I know that Dr. Watson had a question.
Yes.
Go ahead, Dr.
You want to ask, Dr. Watson?
Yeah, thank you, Rhonda. So I'm wondering if you can comment on COVID-19 and its relationship to grief. And so I am, we're starting to express to me the, can you hear me? Yep. Okay. The number of people who are starting to express to me the grief that they are experiencing that is COVID-19 related, and what they seem to be grieving, and I think I'm grieving it too, is the life that was, and the life that we're in right now, and the life that might be completely different in the future. There's a process of grief that I want to acknowledge there, and wondered if you could comment on that.
Yeah, that's such a good. It's you hit it right on the nail right on the head. It's I think we're all stuck in this. It's nobody knows the answers or how to react to this. This is a once in a lifetime, once in a century experience, and it's shaking us to our core because our core patterns of movement and socializing and function has been completely thrown off. We can no longer go and hug our mother. We can no longer go and gather at church. We can't kind of cluster and even mourn for the people that we're losing because of COVID. So all of the ways that human beings cope with stress and emotions have basically been stopped or we're robbed of most of those things. So this collective grief I think we're all going through is a natural reaction all of us have to any loss or trauma in our life. So we kind of approach it from a trauma lens. And there are various phases of trauma that's been written about for centuries now, or even longer. And almost always the first stages are some kind of mixture of felt loss, some kind of anger, some kind of confusion. It's kind of the classic first response, the appropriate response to a sudden trauma. And just to know that, a lot of times people say, how do we make sense of it or understand it or what to do about it? And sometimes, the answer is really not to do anything about it. It's just to sit with uncomfortable, painful, terrible emotion and do it justice. It's telling us something. Emotions are just data. It's just information. It's our brain firing in a way that's telling us something's wrong. And it's not always necessary to act or have to do something. Sometimes the answer is to sit with it and listen to it. And it turns out when you do think, or you kind of think about what you've been through in your life and other challenges you face, you'll find that you do have certain ways that you will be able to get through this and last and come out the other side. Sometimes even maybe a better person. I've been blown away by, I mean, of course, I've had many patients who are suffering worse with this, but the number of patients that are actually thriving or even doing better with this downtime, with this time to self-reflect, I'm just amazed every day at all the people I've talked to. So I do have a certain degree of optimism.
Hi, Jacob. It's Lana.
You know I trust you.
Hello.
How you doing? I'm wondering if you could speak to vicarious trauma.
So if a friend or a close family member has experienced a loss or a death, how it affects us?
Or in the context of COVID, because I in my private practice, I'm seeing, first responders and a lot of primary, some vicarious trauma that's presenting, or even for people who are working and supporting our African Nova Scotian community who in the middle of doing all the work, when they do rest or take a moment to breathe or stop, maybe experiencing some vicarious trauma-based symptoms so that's kind of that health and wellness perspective. I really appreciate you saying that being able to hold space and without responding and having that really highly reactive brain. But I'm just curious if you can just kind of give some context to vicarious trauma for people of African Nova Scotian descent in this COVID environment who are giving support and giving help.
My Lord, that's like a PhD thesis, but I think I hear you. I think I'm feeling it. You're feeling it. Many of us in the health professions feel it. Most people we see are not coming to see us because they're having a good time in life. It's always, almost always, they're going through tremendous trauma or loss or suffering, and so patient after patient, person after person that we're trying to help, we're humans, and so we also take on little bits of what you call vicarious trauma, and that adds up, and it pays its toll. And it's interesting. Earlier this week, I saw a physician, very, through the military, very successful, highly, influential physician who's always his whole life he's performed under unbelievable amounts of pressure. The things that he's seen worldwide, traveling the world, and seeing me because of this exact issue, vicarious trauma, and thinking that something's the matter with him, as if he's not strong enough or he can't put up. And this is the same report that, person after person will report that, especially first responders. I do a lot of work with them more recently, and almost always there's only a certain amount that any of us can take. And so I think more for those of us who are healthcare providers, more important than ever, especially now, is to be extremely mindful of that, because if we were to burn out too much, we then can't help the mass that may be coming, the waves that are coming, both from physical, the COVID itself, but also the mental health wave. And so, yeah, I think if nothing else, that what you bring up is was important to bring up, because it often can be forgotten that those of us in the healthcare system are human, even though it doesn't always look like that, and we can't always express our full emotions to you in the moment. It doesn't mean we don't actually care and are deeply affected by it.
If I could just say something to the initiatives that Brotherhood is taking. Mario has started a men's book club, which so far is, well, actually, I think it's not just for men. I think it's for women too. Has been quite successful. And Dwayne's there, I think, has undertaken to start an exercise program through Zoom meetings. So we're hoping a lot of our men are going to tap into that as well, and probably we'll add in some nutrition and maybe some mindfulness and a few things that also can help people when they're stuck in the house.
So this is a good time. Yeah, go ahead.
It is a very good time. So I know there's lots of questions that people have here, but we in if we're to consider the time that we have left, we're just going to move on. So that does take us to Falami Jones. We're going to ask you, Falami, to introduce yourself and to talk about mindfulness and some of the ways that we can actually cope during COVID.
Yeah, so thank you to ATTWELL, RHONDA, and Sharon personally for hosting this, and to the many of you who are holding up community with all the work that we're doing on the sides of our desk. I think we are such a phenomenal community. I think when I look out into, at least in Nova Scotia, I'm always so just thrilled and recharged about like how quickly we can organize and become active. So I think continuing to look to community for those things. So Falami, I'm a Hawk Board member. I'm also a mother. I'm a daughter, I'm a niece, and I'm a sister friend to many. So I was really interested in talking with this group candidly, honestly, and having real conversations about what's happening at home in terms of our mental health, in our minds, with our families, and in community. I personally, and again, I think it's so important to speak honestly as we can, have many times have felt overwhelmed and consumed in moments. I don't always reach for the most healthiest options to stay aligned, although I try. God loves my apothic wine. You know, it's real. And these are real times. And so I also think it's really important that we, in these large conversations or in these personal, small, intimate conversations, that we don't feel the need to be perfect or act perfect, but better be honest, look at ourselves as individuals, but also how are our families, how are we coping? You know, where do we need attention? And what are the ways that we can be more tender with ourselves? And where are the places that we need to learn to let go? So I thought I would give just a quick little example. I just finished writing my last exams for law school. I still have a huge paper due. And of course, I don't have my shit together always. And so I needed an extension for my paper. And so I had called the person who's in charge of that. And, you know, it was already said, it's not a problem. Everybody is getting extension. So I was talking with him and, you know, I'm trying to get the extension. And he's just asking simple little questions. And I felt my throat starting to like swell up with what felt like anxiety, and my eyes started to weld, and I could feel like I wanted to cry. But he hadn't asked anything really, you know. And then I felt myself push it away because I'm a mom and because I got to go make dinner and I got to do everything else. And after I hung up, everything poured out. And I cried deep and I cried hard and it felt good, but I felt like, whoa, I had to do a kind of check-in with myself. And I actually wrote on my board, it's like, at least speaking from the perspective of one being a student, but I think just even being a woman where we hold communities and families up, there's not very many times in life that we get to hit stop or pause. And so I recognize that in myself. And I put that out there honestly to say that I know we all have moments of like when the children don't want to come off Fortnite and they're up till 4 o'clock in the morning and you're like, you didn't do your laundry and you didn't do this. And sometimes I'm yelling and sometimes I'm not saying all the right things. And that's okay. So I just wanted to kind of start with that. So what are some of the alternative ways to distressing, or like what is mindfulness? And I thought I would also remind us that, you know, that mindfulness practice is basically, you know, just reconnecting with ourselves and in our ancestral well-being, that there's a place historically that we have used that is innate as African people, that we've survived more traumatic events and life-changing events, slavery as one. We are a courageous people. We've had our children taken from us. We've had our lands lost. We've lost our language. And yet, as a people, we are the ones that smile the most. We cry, we dance, we laugh, we forgive, and we do it all over again. So I think I think at these kinds of times, for me, what has been helpful is to also give myself permission to do those things. You know, it's okay to cry, and it's okay to laugh so hard, and it's okay to find ways to do that. And so just reminding yourself that you come from a great, great people. So I think too what Dr. Cookie was saying in terms of recognizing also, this is the first time in any of our lifetime that we've seen such a situation where you feel like your life is being threatened, your loved one's life is being threatened, you're in survival mode, but so is your neighbor too. And so what happens when you're in survival mode? We hoard the necessary things that protect us, and that includes our feelings. We're super, super sensitive and alert to our surroundings when you feel threatened, and other people's actions and their movements. So if you notice, you're looking at your neighbor, what are they doing? And that's an instinctive response, which is great. But there's balance. And so I think that we need to be looking at how we are individually responding to those kind of fight or flight feelings, and think about that in terms of community. So what are some of the things that help, and I'll speak personally, for me, to balance that? Eating well. If you can eat food that doesn't come from a box, and I recognize that's sometimes a bit of a privilege, don't do it. Eat food that feels good, cook things that feel great, getting outside and breathing in and not forgetting to breathe out. We are melanated people. We thrive in sun, so doing that with the social distancing and isolating, but get outside. I personally have, as I was sharing with my Hawk family the other day, decided to make a list of all the things that I want and have wanted to do if I had the time. So, for example, I want to learn the guitar. I want to interview my mother. I've wanted to collect stories. So I realized, though, that making the list was in itself something that was helpful for my mindfulness, because I hadn't taken the time ever before to really do that. And so I think that those are little things that we can encourage our children and our family members to do. I also listened to a 21-day guided meditation. It's an affirmation. It literally starts with 5 minutes of just this conversation around rethinking or thinking about your abundance, like how to create abundance in your life. And I'll put the link in the chat. I love that because I can start my morning with that, or I can finish with it. And it just helps me to create a bit of focus in my life. Kiss and hug the people in your home. Tell them that you love them. You can do that. And I realized it took COVID for me to kiss and hug my mother. I was so busy, I didn't take the time out to do those things. So that's really helped me. Another thing that I did the other day, because I wasn't getting back to all my emails, was triaging, like being okay to look at tasks or things that are coming up for you and triage that. Like, is this something that I can live without right now? Do I need to fix this right now? Do I need to answer this right now? Is my butt going to feel it later? And if not, it can wait. Those are ways of being tender. To Zoom parties and the host parties, I don't know what I would do without my girlfriends or my sisterhood. I think too, it would be interesting, and maybe this is something that we could talk about as a group later, but if people are struggling with mental health or situations of abuse, is there spots or places where we can have those conversations? And so how do we do that? And then last, I think too, I'm just looking at there were so many things that I wanted to say, but there are 2 free online mindfulness sessions that's being held by the Shambhala School for parents. I'll post it. April 27th and May 4th. August So Jones, my brother, was also going to be hosting in the near future a session for parents on teaching. And so I'll post that. But I'm more interested in seeing what are other people feeling, what's really happening, and how are we surviving.
Thank you. I think that was wonderful and really inspirational. Can we put, we will put information on the HAWK website that you send us, Falami, so that people can have access to that information. And I'm just really mindful of time because we are losing so much of it. If you have questions that we don't get to and comments that we don't get to, please know that you can send them to HAWK and that we can try to get back to you on the website, put information on the website, and take those questions forward. I'm going to move to Reverend Beals and to Donna Smith-Darrell and have them talk about what they are doing and what could potentially be helpful. And then maybe if you have questions related to or comments related to what Falami said, as well as Donna and Reverend Beals, then why not let's ask them together, and then we can have a bit of time at the end of this before we move on to rural Nova Scotia. So please, Donna Smith-Darrell and Reverend Dr. Cheryl-Ann Beals, you could introduce yourselves very briefly and then tell us about your work as it now stands.
Good evening. It's Donna Smith-Darrell. I guess that's who I am. I just discovered that my iPad is giving a little flash, so I'm going to run out of the batteries run down, and I'm quite a ways across from the plug, so I will talk very quickly. Actually, I am part of the COVID group, and in that role as coordinator, I am David's, Dr. Hawes' partner in terms of calls, and you've heard about that, so I won't go over that. But Reverend Beals and I have been working together, and basically what we're looking at is looking at mental health and spirituality, which go hand in hand, and looking at developing some things that we can use virtually that will be helpful, giving some information about mental health and spirituality and how they work together. I think that sort of is it in a quick nutshell. Reverend Beals, I'll let you go next.
Hello, everyone. I'm Cheryl-Ann Beals, and I am Director of Clergy Formation and Wellness for the Canadian Baptists of Atlantic Canada. So I work with pastors in their well-being and spiritual health. And I am working as a coordinator with the team for the AUBA. And so part of my role is to liaise with the pastors in the communities, as well as to work with Donna and to look at how positively our spiritual well-being can help us as we learn to cope in this situation, and how a faith is something that can be a great help. Also, it helps us to grow. So how we can grow, develop resilience, and grow through this challenging time.
Okay, I just want to point out that Donna Smith-Darrell is on the board of HAWK as well.
Sorry, I mentioned that.
Yeah, I was gonna let you not mention that. So
past president, past president for many years of the Health Association, and yes, I'm on the board of the Health Association, and it has been quite an interesting 20 years.
All right, questions for Falami, for Donna, for Reverend Beals, or comments? We invite them. Anyone?
I'm just going to make a really quick comment. So thank you, Falami. It's just the mindfulness idea, and that and I practice mindfulness in my teaching, but I would encourage you to do it at any time. And the 5-minute vacation, as we often talk about, is very important. And the breathing in and out is a big part of mindfulness and really centering yourself. Yeah. And you can do it at any time. And it's giving yourself permission to acknowledge the thoughts that are coming into your head. And we sometimes try to force ourselves while we're working to push those thoughts out. And they'll keep coming unless you acknowledge them and then push them aside. And so it's really centering yourself, centering your breathing, and really centering and owning the space you are in at that time. And focus on your breathing. Focus on your tension in your hands. You know, do the tension, tighten them and loosen them. Your feet, your toes. Really get your body to be aware of itself and then release it. And as you release that tension, you're releasing some of your stress. So you need to first acknowledge that it's there and then let it go. Acknowledge it's there and let it go. And if you take time throughout your whole day, whenever those thoughts are coming into your head, and take the time to acknowledge the thoughts, center yourself, push them away, you'll find yourself moving through your day a lot easier, as opposed to just saying, I can't think about that right now. Because you need to take time to think about it, or it'll just keep coming into your mind. So I just encourage you to acknowledge what's happening right now during this unprecedented time. And you can take a 5-minute mindfulness throughout the whole day. And it just really helps to cleanse your thoughts. So I encourage that.
Thank you, Barb. Anyone want to add?
I have a question for Reverend Beals. Reverend Beals, in this time of lots of challenge and distress for folks, and in addition to that, we've had lots of loss of loved ones. What other approach, and you know, as a Black people, how we have our homegoing services. And we're not able to do that in the like manner now. So any suggestions, any ideas yet in terms of how we can deal with loss in our non-traditional manners?
I think one of the ways is to be able to come together and celebrate online, to tell stories, to talk about our loved one, to share ways they've impacted our lives, what we're thankful for, things like that that allow us to express what's going on, what we're feeling, and our sense of loss.
Yeah.
Yeah.
Okay. Yes, it's just such a difficult time for all of us. But I do appreciate very much the suggestions that were made to help us stay healthy. And if you are a person of faith, certainly prayer and reflection and reading of scripture is also very obviously a very important thing for you and for us. So thank you. I am going to, again, because of time, it's not because we could talk about this a lot longer. I do want to invite into the conversation Reverend Phyllis. Reverend Mother Phyllis, are you there?
I'm here.
All right, wonderful. Reverend Mother Phyllis, and we have Tara Lee Reddick. Both of you are calling in from rural Nova Scotia, and we know that what we are experiencing in every part of the province, but I think we are experiencing them differently in rural Nova Scotia. And I want to just let people know, I know it's 6:25. We do have the Zoom call for a bit longer after 6:30, so I'm not going to panic, but I do want to invite Reverend Mother and Tara Lee to speak. Reverend Mother, if you want to go first, both of you please introduce yourselves and then tell us about what you're experiencing and what you'd like to share.
Okay, I'm Reverend Phyllis, and I'm from Sydney, from Cape Breton, and I'm the rector of St. Philip's African Orthodox Church. First, I want to say that good evening to everyone, and you have no idea how well it feels to hear your voices, familiar voices, and know by the grace of God that you're all well and safe. So these teleconferences are very helpful. I also want to compliment Hawk for and the ABSW for arranging these, because the information is invaluable, and I've learned so much just from them. I'm going to be very quick because I know we don't have a lot of time. I want to share my experience with you through this trying time, which I believe will represent many others in our community. Due to my health issues, I am considered amongst the vulnerable. My immune system is totally compromised, and before this virus outbreak, my doctor had already cut me off of doing hospital visits, which is one of my favorite things I had in my ministry. I reached out to Hawk to give some good information and facts and ways to help seniors during this crisis, because seniors became my main concern. One of my big challenges, though, was the reducing of some of my healthcare hours. I have VON and home care coming in, and to say the least, I was upset, and I actually took it personally when they told me they were cutting back. But once I began to learn about this virus and how it affects people, I understood why it was important to reduce hours and the personal contact. So, and actually what happened is, once I got the information about the virus, I actually cut some of the time myself even more. I must tell you, in our community, people are very caring. But here, it seems the numbers, and I might be a little off, the doctors may know more than myself. I think we're up to about 800, or a little over 800 that have the virus. Now, unfortunately, they're not breaking it down. So I don't know how many there are in Cape Breton. And we keep asking because you want to know. I believe that there's been 9 deaths total. I don't know if that's gone up in the past few days. But even just those numbers is very scary to us. Many of the elderly, though, have families who are looking out for their welfare by making sure they have food, dropping it off at the door, and keeping their distance, explaining what is going on, which is really hard for some of the seniors to understand. They're very confused, and helping them to relieve their fear. Some strongly are still afraid. Others are kind of getting used to the way things are going. And most have questions like, what's happening here? And what do we do? My biggest, I heard you talk about grief, and I was glad. I didn't understand that I was grieving, but I am. My grieving is not being well enough to be a part of going out and helping others, because that's what I like to do. So the fact that I'm in the house, I have to find ways of reaching out. And I do that by keeping in touch with people by phone. By phone, right? Hello. And keeping in touch with my church folk, which is very important to me. I have people call me on a daily basis, or at least every second day. A niece calls to check on me in the morning, afternoon, and before bed. I have another niece who I know she's there if I need anything. I've been, through this process, I have to say, I've been really blessed. The connections that I've made with community, like the Polish church, Tom Urbaniak, his wife, they once a week, they check to see what people need in terms of groceries. They pick them up, they drop them at the door. My groceries are dropped at the door so that I don't have to have contact. And what I'm doing, and I say to myself, I think should have been doing this all along, is I sit on my chair by the door and I wipe everything down. I sanitize, you know? Just listening to some of what Dr. Watson said today even makes me want to do this more. My worries are, I worry about those who have mental issues and can't handle staying home, and the self-distancing because it adds to their illness. And I think you all understand that. I get frustrated when I see people outside, I can see from my kitchen window, and they're just walking like nothing's going on. But I have to tell myself, you don't know their story. You don't know what's going on. We do have issues of drugs here. And I'm sure, unfortunately, those that have that issues they just can't, I don't think they can understand the self-distancing. I have a note up on my door because sometimes they would knock on my door, you know, for some change or whatever. But I have a note on my door now that I'm only accepting my home care workers and my VON. I worry as well for those who have received assistance and will be expected to pay back in full at the end of this. That's going to be a problem. It may be solvable now, but it's going to open up a whole can of worms after. I don't know if you want to talk about that. The other thing is that maybe we have the wrong concept of what the United Way can do for us. I say that because I've been getting phone calls that people have been trying to get a hold of the United Way. I checked it myself when people were calling me. So many people were calling me, and there's just a recording saying that the line is unavailable. I don't know what's happening with that. If we're giving help, we need to make sure that we're giving the process and that we're keeping up with what it is we're saying. Lastly, I think our community are trying their best to follow the rules. Like all communities, there are those who will make the decision not to follow them. We need to be cautious of those people because you don't want them spreading, you know, spreading the virus. A big help to us is our pharmacy here in Whitney Pier because they deliver our meds, and that's a huge thing for me. I'm sorry, I'm kind of all over the place there. For me personally, I have no problem staying at home. I don't see it as a lockdown. I see it as God's protection. I see it as a responsibility to my community, as my little part to keep safe and keep others safe. I want to do more. That's my grievance. I really and truly want to do more. I want to help people more. But I believe also through prayer, respect, caring, and love for one another, this too shall pass. And it certainly is challenging our patience and our tolerance.
Well, thank you, Reverend Mother. I think you helped some people just by what you said. You always inspire me, and we appreciate you and appreciate what you do for your community. I know that there are two answers out there. You had asked questions about numbers. Dr. Watson has an answer for you. And with respect to the United Way, I know Veronica may have something to say about that. So I'll ask for Dr. Gaynor to answer the numbers one, and then we'll throw it to Veronica about the United Way.
Okay.
Yeah, and thank you for those comments, Reverend, and insights. It's lovely to hear what's happening from your perspective in that part of the province. So just so folks know, we do, so the team that I work with every day, it's not a big team, but we are doing some crazy amount of data crunching every day. And so we actually look at the numbers of new cases every single day, and we publish them to our health system partners. Our hope is that we'll be able to publish them publicly soon. We're just looking for the right platform for that. Some folks may have seen some of the fancy dashboards that exist in other places, like Hopkins University had put out a dashboard, the WHO had put out a dashboard. There's actually a program similar to that that we're playing with in Nova Scotia that might allow us to put that information out publicly. So stay tuned. But in the meantime, here's where we're at with the numbers. So I said about 850 today, which is true. It's about right. And of that, the vast majority are in the Halifax region. So about 650 of those cases are in Halifax region, and then the remaining 200 or so are kind of spread out throughout Nova Scotia. So it's about a third and a third and a third for each of Eastern Nova Scotia, and for our data, we include Guysborough and Antigonish County in that, and then a third in Northern, and then a third in Western Nova Scotia. So it's roughly between 40 and 50 cases in each of those areas. The majority of those cases have already recovered. So in terms of new cases every day, what we're seeing in those parts of the province isn't the big jumps in numbers. It's not that they're increasing by 10s and 20s. They're increasing by 1s and 2s for the most part. And so that's been the stable kind of consistent pattern for those parts of the province, including Cape Breton, throughout this thing. The challenge, though, comes back to what I said earlier. That will only stay stable if in those parts of the province we can keep the virus out of vulnerable facilities, so in particular long-term care facilities. So where we are seeing the numbers climbing in Central Zone, a lot of that right now is being driven by long-term care facilities. Our deaths are also being driven by long-term care facility cases. And so we're up to 16 in the province of Nova Scotia as of today. We continue to monitor every day, and the majority of deaths that we've seen in the past 10 to 14 days have been in long-term care facilities, which is really heartbreaking. So that's what we're trying to avoid in every part of the province. And like other parts of the country, the challenges are going to be in the urban areas. So obviously there's a concentration of those facilities, for example, in Sydney, that, we're watching fairly closely, just like we are the ones in HRM. So I hope that gives you a little bit.
Well, there.
Yeah.
No, I'm sorry. Go ahead.
No, go ahead.
Will there be any testing done in Sydney?
Yeah, there has been already. So there is a testing center open in Sydney, and to the extent that if we see increased activity, I'm just making sure I'm not on mute. If we see increased activity in any area of Cape Breton, we would look at what strategies we can use to get to that increased activity. And often, because we've got testing capacity in Nova Scotia that the other provinces don't have, we're able to move our testing strategy even earlier than the numbers might suggest. So we're not waiting until it gets really bad. In most cases, we're just going in with the testing early to see if we can do a little bit of a preemptive strike.
Thank you.
Okay. Veronica?
Okay, Phyllis and folks, in terms of the United Way, and by no means, folks, am I a guru at this. I just happened to find out, like you, Phyllis, about this funding that the federal government announced, $350 million to support people during this COVID time. I had a contact at the Halifax United Way. Even prior to this coming down, I was in touch with him about funding to help us with the ABSW HAWK COVID initiative throughout the communities, our African Nova Scotian communities. And immediately he responded and asked a couple of questions. Number one, were we a charitable organization? To which I was able to say, yes, ABSW is a charitable organization. It appears that they'll only provide funding to organizations that have a charitable status under the CRA. So once it was cleared that, then he said, look, this amount of money was just announced. They don't have all the details around it yet either, but he did say that there was a stream of funding that he can get monies out of the gate quicker for, and that was for seniors. So I said, hey, we've got a large number of seniors that we're working with. Here's our list of needs, such as, of course, the groceries, the sanitation supplies, the masks, and then even, financial support to pay for oil and electrical bills while the seniors are at home because nobody can get out these days. So they took that, they heard that, and they've now asked me to pull a budget together and get it to them, and they will hopefully assist us. So we're looking at support for all of our communities provincially for our African Nova Scotian community. So I do ask that if you have specific ideas or needs, more so needs for your areas, please let us know, because we can funnel that money. Whatever's given to us, it's our intent to funnel it back to our communities.
Okay. I will definitely get something. And who do I send this information to? Through HAWK?
Phyllis, you have my contact. You can send it to me.
Okay.
All right. Well, I'm going to thank you so much, Reverend Mother. I know time is it's too late. We are going to turn this over to Tara Lee, who's going to wrap this up for us. But first, Tara Lee, we want to hear from you. Please introduce yourself and tell us about your experience in Antigonish and some of the work you want to see done.
I won't be too long. Can you hear me okay? I'm in my car now.
We can.
But my name is Tara Reddick. I reside in Antigonish. My roots are in Upper Big Tragedy. I work at the Antigonish Women's Resource Center. I'm the African Nova Scotian co-facilitator there. My colleague, Tanya Pelly, she's also an African Nova Scotian facilitator. And we've been working with the communities, Upper Big Tragedy, Lincolnville, and Sunnyvale, collaborating, trying to come up well-being, just trying to come up with ways that we can combat this in our communities. So this came out of a need or a gap that the Antigonish Women's Resource Center sort of seen within their organization that didn't see rural women, didn't see African Nova Scotian women coming into the center. So right now, COVID, can everyone still hear me?
Yes, we can. We can.
Sorry. Seems to be a little lag, but so right now COVID is sort of, I guess, hindering that, establishing that more of that gap. But I mean, our Antigonish, our Women's Resource Center is still up and operating. We still have our Guysborough County outreach. We still have our sexual assault nurse there, Lindsay's clinic, but she's seeing individuals by a phone need basis. Emergency financial assistance is still there. Our newcomer supports and things like that. In terms of our our rural communities, like speaking with my colleague Tanya, who she's situated hard with some of the things that are going on with Zoom and all of that. Our communities are elderly in age. A lot of our communities are elderly in age. So that's one of the things that we've been seeing that have been really challenging for us. So, making phone calls and, during this, with people that could be abusive. So we really are disseminating information to let people know that the Women's Center is still there. We are still there to provide services and to help. Although we have unique challenges, things that I've been concentrating on, getting information that's sent to me, throughout the communities. And our last sort of gathering was in March. That was when the COVID really started coming. But we've had Zoom gatherings. Reverend Dr. SHARON Beals is here, and she's sort of guided us through a mental health with infusing spirituality in there, and that was community kitchen table talks, like trying to get us together because we're so used to being out and doing our stuff within the community. And so that's been a very trying time for us. And we've had some deaths down here too as well, and not being to address the sexualized violence that sort of need that we have is really, really just trying to get the information about the Women's Center out there, that it's not physically open, but we have people that can provide, we do have an emergency fuel fund. We have, we have counseling. We have our women's Lindsay's clinic that is dedicated to our women's health needs. And so it's been a trying time, but trying to use our resources outside, within our community, outside our community, and thinking about the future, thinking about doing a community a garden in the Sunnyvale ball field now that's overgrown, trying to think about things that
we're losing. Okay.
Down here, but that's my part, is that women need women. So, and we're trying to do that. So, Tara, I see that Sister Mary Desmond's on here. Sister Mary Desmond's Upper Big Tragedy resident. Okay, that's it. I know you guys are still there.
Yes, what's happening is that we're losing your voice from time to time, Tara-Lee, but what I want to say is it would be really, really great if you could send information about where people can go to get help and the fact that you're still operating. Send that information to myself. You have my email, and Carla, and we'll put it on the web, on the HOC website. Okay? And also, if there are questions, go ahead, Tara-Lee.
Yeah, that's excellent. Yeah, it's. I think there really needs to be, you know, we get some information down here, the Black social workers and other things, but it seems to me that maybe there's a lag in the information getting here. You understand, in terms of like, okay, well, is there somebody with this big master list? I think that there needs to be, I don't know, there's just some sort of disconnection in terms of dissemination of information that sometimes comes from outside of our community too. And so I don't know how that could be addressed, but
well, you're on the HOC list, so whatever we send out now, you will get, and and then please do send information to us so that we can put it on our website. And if people have questions around domestic violence, around sexualized violence, you will be a resource for us, Tara-Lee. So please send that to the website, the HOC website. You can call it in. The info@HOC number is on our website, and we will certainly follow up for sure. So it is 6:47. It's way later than we were planning to be on the call tonight. I just want to say two things to you, or maybe three, very quickly. Again, your questions matter. HOC is responsive. We will answer you. We will put information on the website. Anything that you send to us, Carla's very good at turning that around and putting it on our website so that we can all have access to information. This will probably not be our last call, but we haven't planned one right this second. So we're going to look at what the needs are and see when we will be able to do this again. We're still going to be under a state of emergency for a bit longer. So we know that you know, this is one opportunity for us to bring everybody together and share information. I want to encourage you all to stay safe. You are, as Valami so beautifully put it, we are a people with an amazing history. We are a resilient people. Remember that and think about that as we move on from day to day and we overcome so many things that are coming our way. Treat each other with love and kindness. Hug who you can. I have to hug myself when I FaceTime with my kids, my grandkids, because I can't hug them. But they get it. They understand. It's a beautiful way to let them know how much we love them, Papa and Nana, right? And also, I want you all to share information with each other, everything that you have to say and everything that you think is important. It's important to HOC. It's important to all of us. And I want to say, on a much lighter note, no matter what you hear from the White House in the United States, please do not swallow a torch and do not inject yourself with Lysol. Okay? No. So
absolutely not.
So keep that in mind. Know you are loved.
We'll try not to.
Okay. Good night to everyone. Bless you all.
Take good care, everyone. Thank you so much.
Good night.
Yeah, good night.
Good night.
Good night.